Welcome to NeuroNoodle's Neurofeedback and Neuropsychology podcast featuring tech legend Jake Gunkelman. He's the man who has read well over 500,000 brain scans, and Dr. Marie Swingle, author of iMinds. Our goal is to provide information and promote options for better mental health. The NeuroNoodle podcast is supported by listeners and businesses just like you. Yay! Gunkelman.
What's left of me, at least. I somehow didn't take my afternoon meds yesterday. So yesterday evening, I went into a steroid crisis. My back turned into a gigantic rash. It just, it's just stupidity.
Yeah.
Freaking near killed myself,
Come on, Jay. Can't be doing that.
I know. Normally, Renita asks me, did you take your afternoon meds? Because she catches me half the time having not gotten them yet. And she didn't ask and I didn't say, and it was just one of those days.
Oh, man. I think it was off for everybody. No, you didn't take your meds. I think we had one person show up for chat, but the one person that did show up, Tabaloo, I put the offer out there. If somebody wants to join us on the day show, if we didn't, cover what they wanted in the night, then I send them the link. We'll see. But
I'll stick to child, so we'll have a fair amount of discussion on that.
Yeah, absolutely.
We end up having only one show up, but it's the right one, sort of,
Right.
I've often said I will do the same lecture even if it's an audience of one, and that, kind of how yesterday went, so.
Well, unless you're in Sweden. I can't believe Dr. Marie didn't want to do the show at 1 a.m.
I can't imagine that.
Are you talking about me?
Oh.
Actually, I have done it before, and it didn't matter because I'm getting home from a dinner party or something and staying up another 15 minutes for it to just launch in. That's fine. But last night, I apologize. It just the energy.
Oh, you didn't miss anything. I was off. Jay was good on the show, but his meds were off.
Yeah, I forgot my afternoon meds, and I went into a steroid crisis yesterday evening, and my back, I had a rash. My whole back was a gigantic rash. And
I'm so sorry.
Well, my immune system if you don't suppress the immune system, it turns on and it can eat you right up,
Yeah.
So anyway.
So Dr. Marie, what we had was Tabaloo. Did I say that right, Jay? Tabaloo? All right. I know he emailed 20 minutes ago and said, hey, I'd like to take you up on the offer of coming on the show after being in the chat last night. He has an autistic child. And I said, okay, fine. Come on. Dr. Marie will probably be around and we can get into it. And maybe he's figuring out Zoom, downloading it. Who knows? But maybe we could talk about autism a little bit. And and then the other thing,
I gotta take care of the dog.
Yeah, go ahead, Sky. And then Dr. Marie, what we're talking about is maybe the show's too early, that we have to put it out a little bit later, because it seems at the end more people start showing up. So I'm thinking about putting it back an hour or two. What do you think?
If I'm not if you put it back 3 hours, then it works again in Sweden. I can be up in 5. That's not an issue.
What are you doing in Sweden?
Well, Christian, my partner is Swedish. So I spend as much time working remotely here as possible.
Got it. Okay.
Yeah. And then you probably notice, I'm going to be from Chicago or from England. I do hop around a lot. Traveling for work. I love that component, but it takes it out on you. And Santiago, can really talk to that as well. So maybe we should do a show on self-care for the people professing self-care.
Jet lag, Well, Santiago showed up yesterday. That was.
We did.
Yeah.
Good. Okay. Did you guys talk about sport performance to take advantage of his presence?
I don't think that was a major topic that came up.
Okay.
There was a lot of different discussions, but
Okay.
I don't think anything on sports. But
Well, we didn't have you, Dr. Marie, to keep us on track. We got on a couple tangents. And, because that show, the audience kind of dictates what's going on. And then if,
That's fine. That I mean, there's a pleasure to that. I love being live and off
yeah,
the
yeah,
cuff, so to
yeah.
speak.
yeah,
Well, it's
so
just like, you're throwing a party and, only a couple of people show up. And
Yeah.
we may have, like I said, we may have to put it out a little bit later. It's the summer. People have other things to do. I get it, but we're
Well,
working.
again, Vancouver time, that really works for me.
Yeah,
Because then it's kind of nice to have a half an hour after your last client
right,
to
right,
take a
right,
breath and jump
right.
in. So that works on my end. On that note, before I digress, can we get the topics the day before? Because I'm just like trying to scan in a couple of minutes.
Here are the topics. Google News,
Yeah.
neurofeedback, mental health.
Okay. All right. We
No,
can do
well, it's
that.
whatever's popping up at the,
Okay. Yeah.
uh, because there's some stuff that's 4 hours old versus, 2 weeks old, and
Yeah.
basically it's all the same stuff. And now that we had Tabaloo, on the autism, you guys have presented so many times on autism. I figure we could go to that, and then
Yeah.
if he can't, if Tabaloo can't make this show, then at least he can see this, and then we can, have a
Yeah.
Q&A, later in the chat
Mhm.
next week.
Yeah, no, all
So,
good. I just
so I,
we're talking about my for better for worse. It's not a perfectionist streak, but I like to kind of know if I'm going to be asked a specific something on an article, then I like to actually have read the article. But if we're just off the cuff and there's nothing referencing it, then I'm cool.
no, that's my advice. That's what I saw. And even
Okay,
if it's just a headline, you're looking at the headline.
that I can
Oh,
do.
here we go, Jays. There we go.
Okay. Okay, cool. By the way, Jay, I know that you need to balance your work and family life too. Does later work for you?
I start at 6 a.m. and going later ends up making it too long a day for me.
Yeah,
So,
yeah.
but I'm just one of the group, so uh, don't
We're not
ditch
doing
a
anything
perfectly good
drastic. We're
You just
circumstance.
happen to be the master of the group,
That's
however.
right, Jay.
Yeah,
We'll remind you to take your meds. At least you'll do it on a Wednesday from now on.
I'm just an old tech. So
Yeah, yeah, yeah.
anyway, uh, the,
Okay, what do we have here?
this is actually from Autism Science Digest, which is the Autism one. Um, it's not a journal, but they call it their journal. It's
Mhm.
a if they invite you to submit a paper, it's already accepted. They might look at the grammar or something, but they don't. They invite people that they want to have write something up. So this was Dr. Newbrander, Cynthia Curson, Michael Linden, and myself, and we basically wrote this up. Now it's oriented not for professionals as much as it's oriented towards parents.
Okay.
So we start out really basic. What is neurofeedback? What are the brain frequencies?
Nice.
Just step by step going through. Talks about, and this is DSM-4 era. So we still had Asperger's as a category. I mean, I thought it was useful myself, but they ditched it in DSM-5.
Well,
But this,
before you even go on there, Jay, I mean, most of us that work with autism think that that was absurd, and we still kind of, many of the parents as well still refer to or differentiate between
yeah,
Asperger's and autism. So I'm more than happy to ignore that as
yeah.
well.
Anyway, there's one little anecdote in it, but the references. But this is basically oriented towards parents to give them the kind of the full rundown on QEG based feedback and the different clusters or phenotypes basically within the autism category, and you know, depending upon what kind you have, you end up altering the training to match the underlying pattern. But this is older, as I say, but it's parent oriented. But these are invited articles. They're not peer reviewed in the same way as a journal normally would.
What year did this come out? This paper?
I'm trying to remember the year. I might be able
Mid
to
2000?
somewhere around there.
Okay.
Okay.
But it was DSM-4 still, so it gives
Yeah.
it a certain agedness,
Okay.
But then I'm old too, so.
Well, again, Jay, trailblazer. This was pretty amazing for those days, and again, parents were, oof, blind.
So
Lots of
this
blind
is
lead in the blind hair.
this was written for parents. It wasn't written for neurofeedback professionals because it starts out with the very basics um, and how neurofeedback is set up
Yeah.
with an amplifier and filters and A to D converters and the patient and the feedback, all of the basics. And it also discusses each of the EEG band ranges and kind of generally what they represent. And at that point, we do go through and kind of talk about how neurofeedback works. Um, this table represents, again, DSM-4 era, where they still talked about Asperger's, but these are different endophenotypic patterns, different clusters, different types, basically, of the autism spectrum as they present based on their EEG patterns. And it's not a behavioral differentiation. This isn't, this one has rage events or this one's socially isolated. I mean, there's no, this is all based on brain activity. So when we train people to get the brain working well, the behavior and all of that follows. So we're working on a foundational system, not simply the overt behaviors. The behaviors will fall in line when the brain is working fine. So and so this is available, and it's again a little bit dated. This is Dr. Newbrander up in the Northeast. He's an MD. Cynthia Curson, Michael Linden, who has specialized in ADD prior to this, and myself back in an earlier version, obviously without quite as much wrong. So, the I think uh, the switch from ADD to autism as a target audience for neurofeedback was kind of driven by the inattention, the hyperactiveness, the kind of behavioral issues that were similar, and uh, the EEG does occasionally have discharges.
Well,
The
in the
more
day also, Jay, let's not forget, at the turn of the century, lots of individuals were absolutely mystified with autism. A lot of individuals didn't understand it. There was little to no treatment. The treatment that there was like experimental in a very negative sense, causing more harm. So neurofeedback, I could say that there were years where it seemed like a good 40% of our practice was autism, until individuals started to, or the community started to get a handle on this. Yeah.
Well, the autism spectrum is a broad spectrum,
Yeah.
and the good thing is that we can target the various aspects of it nicely
Mhm.
with brain training. The the uh, autism ends up having high incidence of epileptiform content in the EEG.
Yeah.
About 60 to 70% of the autism population will end up showing a discharge in the EEG.
Yeah.
And if you have a discharge in the temporal lobe, it usually doesn't show as a convulsion. It shows up as out of control emotion.
Yeah.
So in autism, antipsychotics are used if there's a behaviorally difficult self-harm or acting out. The problem with that is that it makes the discharges worse.
Yeah.
So if the behavioral outburst is triggered by a discharge, the treatment with an antipsychotic will actually make the issue worse, not better. And before you select the medication, it's a really good idea to actually to look and see what the underlying patterns are and what medication would be appropriate. Psychiatry doesn't typically measure the brain's activity before they pick their medication, but it's actually the right thing to do. And in biological psychiatry, they actually are starting to actually look at the brain that they're about to treat. Medication is used to influence behavior, but it treats the brain function and hopes to influence the behavior. And if you're there's no direct link between the brain activity and the behavior. It's a loose link. We can directly impact brain function, and the behavior will follow. So we basically try to normalize or optimize brain function, and at that point, uh, we watch things kind of
A lot of
fall in
work with
line.
autism, just to really simplify it, if there are any lay people out here, is just turning down the noise in the brain. You know, that sense of overstimulation, I find that a lot of individuals with autism feel. If you can just turn down the noise, so to speak, individuals feel a lot better.
Yeah.
Jay, could the key word that's sticking out in my mind is filter, and I know you had it on here, but it was a different context. Does that mean that whatever's going on in the brain, the filter is just letting too much in and you're getting overwhelmed, or what's going
You're trying
on?
to get a generalization.
Yeah, right,
We have to be specific to the individual because this is
right.
a broad spectrum. If you use a generalization, you're missing 90% of the people. That it's a very diverse spectrum, and you can't use a canned approach to the entire spectrum. You may have a one-trick pony that works with one specific feature, but uh, you can't fit everybody into a size 42 long. I mean
Hey,
Especially
Jay,
me.
can we perhaps take advantage of your expertise? Because there are kind of two, I'm going to air quote types. I don't really mean types, but two common presentations are, the slow, gradual discovery versus almost immediate onset or a regression profile. What do you know about the differences, and what can you share in terms of those differences and how to help those two different profiles, if you'll permit the generalization?
um, I You're talking about a time frame
Yeah,
degradation
yeah.
that can happen.
Mhm.
One thing about individuals that have epileptiform discharges is that when you create a discharge, it makes it easier to make the next one, and it may recruit another little bit of the brain. So the epileptogenic network can end up adding on additional areas of the brain.
So
And
a compounding effect is what you're
yeah,
speaking.
and
Yeah.
and essentially spreading the abnormal discharge to more areas of the brain and thus more function, more
Mhm.
dysfunction. We need to stop the discharges because if you fire together, you wire together, and that's how it spreads. But if you don't use it, you lose it. And that's how, if you stop the discharges, and hold them at bay long enough, the network that makes them will start to disassemble. A spoke here, a hub there will fall away. And you can kind of see in the behavior as it changes what area of the brain has lost the discharge. In some individuals will end up having epileptogenic potential that will cause them to actually collapse, and those are frontal discharges, and um, a drop seizure where the person just collapses. Well, that's when both frontal lobes are lost, and you've lost motor control entirely. And when that's gone, the frontal lobe is free of the discharge enough not to drop you. It might be only one half that's still left intact, but it's enough to keep you from falling to the ground. And a bit at a time, we see the network that supports the seizures disappear. And I've worked with intractable epileptics, not just autism with discharges. And autism with discharges that aren't having seizures are easier to stop than an intractable epileptic. In the autism spectrum, we expect to take a bit longer to train away the problem than a simple ADD, if there's any such thing as a simple ADD. Um, in the ADD population, 30, 40 sessions is quite commonly adequate. But with the autism spectrum, or if you add on a learning disability to the ADD, you end up going 60 sessions or sometimes more.
Yeah, if I
If
could
the
just echo
if the
that.
autistic kid has a discharge, epileptic discharge, it's the higher end, not as quick.
No, our autism clients are very, very long term, very long term. Yeah. And I mean the goal changes as well.
Yeah.
Any thoughts on that article that I think it was Joshua that sent it, not Pete, but in terms of the new information of different forms of toxin, specifically the plastics. That was the first that I had heard of that. But I do know that anything that invades the good old brain blood barrier can give a whopper. But any thoughts on that? I'm just slowly absorbing the theory at this point.
Well, microplastics
Mm.
are everywhere.
Yeah. Uh,
They find it in Antarctica. They find it in rain. It's ubiquitous at this point. And they had a pretty good idea early on in 3M that there was potentially a problem, but
yeah.
um,
Mm.
you know, monetary gains
Yeah. Yeah.
overcome a lot of concerns.
Mhm.
The dollar sign is pretty
Like
attractive for
leaded
some
gas, we
folks.
knew about that eons ago, but there was too much money in it.
Yeah.
Yeah. But in terms of how that the theory that could affect and then effect or affect and affect um, in utero development based on hormonal change. I found that fascinating. I mean, we
Yeah.
know how plastics can affect the estrogens, but I was a bit fascinated in terms of how that also affected potentially testosterone, and
And
testosterone influence.
neuroestrogen as well. So
Yeah.
it's um, plastic's organic,
Mm.
and it can end up influencing other organic compounds because it bonds so readily. And
Yeah. Yeah.
um, the smaller the particle, the more likely it is to adsorb, to stick on other entities, so it can
Mhm.
piggyback and be taken in. And
Mhm.
uh, um, not too many things make it through the blood-brain barrier when it's intact,
Mhm.
but blood-brain barriers can become leaky with head
Yeah.
injuries and some other systemic illnesses. You can end up losing the intact blood-brain barrier. So um, it's not a fun thing to lose. Um,
Yeah.
so I'm not well enough to end up being an example for anything with respect to brain. Mine's leaking cerebrospinal fluid out, and um, I lost my pituitary to a brain tumor. So don't do what I've done. But I would suggest that neurofeedback is a good way to optimize and to minimize problems and optimize function. And the problem is that you really can't just go into neurofeedback as though it's one thing.
Yeah.
There's
Yeah.
lots of different techniques. Joy was just touching on that yesterday with a list of the various kinds of infra-low, infra-slow, slow cortical potentials, amplitude training, Z-score training, Loretta Z-score, all the various kinds of trainings that are out there. So it's not neurofeedback isn't neurofeedback isn't neurofeedback. You have to pick the kind of neurofeedback that's most appropriate to your
And don't
concerns.
forget the evil non-neurofeedbacks that call themselves neurofeedbacks.
Yeah, we do have taggers on that are commercial frauds that end up using the neurofeedback word to try and get their device into the field. And actually, one of them actually showed up at a major societal meeting as a vendor, and the rest of the vendors complained vociferously to the organization that this was not neurofeedback and they didn't have any business being in there competing for clientele with a $15,000 fraudulent device. That device, by the way, you could open it up and it had a random number generator that would kick out uh, uh, diagnostic impression things, preform statements, and it was supposed to test you and then give you a result that would be a match. And they actually went up to Canada with a news crew to do a documentary, and the owner of the company was obviously not intact mentally. You know, he came out in his drag persona as Desiree something, and was in a cross-dress outfit. I mean, if a news crew is coming, the least you could do is present yourself in a reasonably sane way. But
Truth is always better than fiction. That's all I can say here.
Unless it's the Olympics.
yeah.
Tabaloo's got a question, Jane, Dr. Marie. If you can see it in chat, I'll read it for you. Is neurofeedback effective for regulating the vagus nerve, or would working with a chiropractor be a better option for calming the vagus nerve?
In fact, the vagus nerve is triggered from cortex. Martijn Arns, who is a major researcher in neuroscience, and he's got a huge number of publications. But when TMS points the magnet at the left frontal area and pulses it, he observed that that location, when you hit it right, actually slows down the heart. It stimulates the vagal nerve. And so you have access to the vagus nerve from the cortex down. There are devices that end up being hooked on your neck to try to tap into the vagus nerve as it traverses into the body. But the vagus ends up connecting brain and body. And you know, Anna Wise, who's passed many years ago now, was wise enough, Anna Wise, to actually, when she looked at consciousness, create a matrix of consciousness that included body as well as brain. And body arousal was measured with the electrodermal system, eccrine sweat glands, which are triggered by the sympathetic nervous system. And so she was looking to see how aroused your central nervous system was in the sympathetic nervous system tone. And that was one axis, and the other axis was EEG arousal. And you could be highly aroused in the EEG and low arousal in the body. That's a whole different thing than high arousal brain and high arousal body, and vice versa. So the brain body connection is something that we need to focus on, not ignore. we're not disembodied brains to be treated as a brain only. We actually have a body attached, and the brain's effect on the body is massive. We have some people who have gastrointestinal distress, and they've been scoped up one side and down the other. It is swallowed barium. They've done uh, scopes, but if they can't find a problem actually in your bowel or GI system anywhere, the brain actually has a direct involvement in that. The insula, which is buried, it's insulated, it's buried deep under the temporal and the lateral frontal area. That the posterior aspect of the insula actually controls all of your gastrointestinal system, the peristalsis, the propulsion of stuff through you, um, and internal sensations. So your internal sensation that's not right, that's painful, if they can't find a peripheral problem, peripheral to who? It's still part of you, you know. But if it's not a peripheral problem, then it's maybe a central problem. And fairly recently, I had a good friend who was complaining, and I didn't know about her history of GI complaints, but she was complaining that she wasn't getting any help from the doctors, and it'd been over a decade of trying this and that and all the various testing, and they couldn't come up with anything. And I suggested, based on actually what we've been doing, that the insula in the brain may be the problem and that they should do an EEG. She went to her doctor and asked for an EEG. They said it's only good for seizures, traditional medical view. But the insula is involved in gastrointestinal distress. There's well respected articles about Crohn's disease and the insula, and the connectivity in the insula changing with Crohn's. And Crohn's is a somewhat difficult to diagnose sometimes, gastrointestinal distress. Uh, uh, but you can also have a discharge. Brains can have epileptiform discharges. Well, the insula can as well. If you have a discharge in the insula, it causes painful contractions in your abdominal cavity. The smooth muscles will spasm. Now, normally a cortical discharge causes a striate muscle, skeletal muscle, to contract. But when the insula is involved, it's smooth muscle. So you actually have a spasm in your abdomen, and that hurts. So abdominal epilepsy was an archaic term for that. That it's not part of the international classification system, but it was very descriptive. But there are current articles about individuals that have abdominal pain, that have epileptogenic activity in the brain that's causing the abdominal pain. And it points to the insula. At the Sassoon Summit in October, we actually have a couple of major talks on insula and abdominal pain, and chronic abdominal pain. A client of mine who's sent EEGs, a few thousand EEGs through the service, ended up having a client who had a discharge, and we identified the insula, and he trained away the epileptogenic discharges with neurofeedback. Unbeknownst to him, the client was being followed by a gastroenterologist over in the Seattle area. And eventually the gastroenterologist noticed that the patient had no longer any GI complaint. And he asked, what the hell happened? And he says, well, they trained this thing in my brain. And he said, what the hell is that? And who was this person that was working with you? And so he got in touch with my client and talked a bit, and they shared a couple papers with the gastroenterologist, who it was shocked. It wasn't part of his medical school training that the GI system was actually hooked up to the insula, and that the insula could cause abdominal spasms. So, um, it was an interesting encounter, and he was struck by the oddity of it. a few months later, he ran into a patient where he scoped up one side and down the other and couldn't find anything. And he sent this to my client and said, could you do one of those recording things and look to see if that funny spot is doing that bad thing? Um, and sure enough, this was another client who had an insular source to his abdominal complaint. So, now you have a GI specialist referring to get the EEGs done on rare occasion. If you do a scope and you find something, you got it. But if you can't find anything, it's time to look elsewhere.
Jay,
So,
this will be an interesting one for the interweb. I've heard stories of people when they have a hard time going to the bathroom that they faint, and it's because of the vagus nerve. What is that?
yeah.
Does that really happen?
Yeah, and in fact, vasovagal syncope is what you're talking about, and abdominal pain is enough to cause you to end up having vasospasm and pass out. And sometimes syncope ends up looking like you have a seizure. You can be twitchy and so forth when you pass out. Occasionally, those people are brought in, and they think it might be epilepsy. They do an EEG and clear the EEG, and it was just syncope. It wasn't epilepsy. It was syncope, and vasovagal syncope is not uncommon. There's some people that simply see the sight of blood and they will pass out. It's another form of vasovagal syncope. But
Does that mean your heart is going really slow, and is that why you faint, or like what's?
in fact, the vagus nerve can slow the heart. The spot that Martijn Arns looks at for cardiac deceleration with the TMS pulse, they actually have a current paper, just published on the intensity of the TMS magnet is something that they look at the motor strip and how much it triggers, and then the percentage of that is used as the threshold for what to stimulate. But if you actually look at the cardiac deceleration, you can tell if you're overstimulating, it slows it too much, or if you're not stimulating enough, it's not slowing down significantly. So they can use
at home.
yeah, they can literally use the EKG deceleration to titrate the pulse and how intense that pulse has to be. So, you know, it vasovagal syncope isn't just peripheral vagus nerve. The vagus nerve actually is hooked top to bottom, and the body can affect the brain, and the brain can affect the body. The vagus nerve is a two-way street. It's not the brain top down regulates the body and doesn't get anything back. The two talk back and forth. So the body influences the brain, and the brain influences the body.
Jay, we started off with autism. Do you want to let's close out your paper here? And I'm just kind of wondering how, Dr. Marie, when parents and little kids come in and the spectrum, what is usually the process? And I know we hate the broad brush, but there are people trying to figure out how do I know I need to bring my kid in? What are the symptoms, and then what are the
Yeah,
possible?
well, I'm just going to kind of respond with the symptoms. What is the experience, or what are the symptoms that are making life difficult for the individual, the child, as well as the supportive family and educational system? So I think, one of the things we're known for is, we label it targeted treatment, and we go after, specific symptom sets to improve the experience of life and the quality of life. And it really depends, as Jay will chime in, what we see on the EEG, that looks like it might be correlating with the reported symptom or the reported experience. And we just move from there. There's some things that we can have amazing success with, like snap the finger, a couple of sessions, and other things that are really long and slow, but parents invest in it because they really, really think it's worth it. There are other things where, we push and we push and we push. For example, if you have a nonverbal a child or a pre-adolescent, 11, 12, the chances that we're going to get any big movement there are slim to none. So, I mean, we also have to respect the boundaries and the barriers. But, sometimes we do have these amazing results with clients where everybody said there was no chance whatsoever of change. So it really depends.
You know, there are autistic clients that end up having white matter change. During the developmental trajectory, the stage at which white matter is laid down, the neuron diameter determines how many layers of white matter have to be laid on top of it to insulate it so it's a high-speed neuron. A very narrow, little tiny neuron might only need 10 layers, but a big one might need as many as 100 layers. And that process is disturbed. If you layer on too many, you shut off the neuron. If you don't layer on enough, it's no longer a high-speed neuron. When you put a coating of myelin on it, the neuron is very fast because the impulse doesn't go what they call saltatory conduction across the surface. It jumps from node of Ranvier to node of Ranvier, little spots on the neuron. So it jumps very quickly instead of slowly being conducted along the neuron. And that high-speed white matter ends up being disturbed. Now, most people will think that the white matter is pretty much permanent. It's not. Neurofeedback can change gray matter and white matter. And that's been shown in work by Mario Beauregard in Montreal Neurological, which is a major institution, a classic major institution in EEG. And it's also been identified in an NIH study by Dr. Jaime Pineda in San Diego. And in that study, they did diffusion tensor imaging, which is a way to look at an MRI and see the white matter. And they looked at it before and after the neurofeedback. And the neurofeedback trained in areas ended up sculpting or changing the white matter in the area that was being trained. It didn't change it everywhere, but it targeted area that was being trained. The white matter was changed and improved, basically, normalized. So it's not permanent. It's plastic. Now, plastic has an awful reputation nowadays. And neuroplasticity isn't like bad plastic stuff. Neuroplasticity is the ability to reform or remold, to change your shape and function. And that plasticity in the brain is how we learn and how we progress. So neuroplasticity isn't the bad plastic like plastic pollution. It's the good kind of plastic, the reformable, fixable brain.
Let's clarify what we're talking about.
The brain that can change itself or neuroplasticity.
All right, I think we're off autism because Tabaloo is asking, after undergoing neurofeedback, have you noticed any improvement in gastrointestinal issues such as constipation, diarrhea, or bloating?
Yes.
Yeah.
Easy answer. Yes.
Yeah. Yeah. And I'm going to give, Jay is the master of complexity. I kind of joke frequently calling myself a KISS therapist in terms of keep it simple, silly. A lot of gastrointestinal issues are essentially a somatic expression of anxiety. Okay, or a body expression of anxiety. And you can look at the brain and see where you have over-arousal in regions that don't really like over-arousal that much. You help with quieting, and you can get amazing changes in gastronomy. Amazing changes. And I don't want to oversimplify, but this is just neurotherapy 101. You can avoid all kinds of medications and antacids and laxatives and whatnot, just with quieting. Yeah.
Isn't there a lot of neurotransmitters in the gut?
Yep.
Yeah.
Second most in the body?
Serotonin is in your GI system is actually the largest source of serotonin in the body. So,
Yeah. Yeah.
everybody thinks serotonin is, just brain, but it's, peripheral. You know, Again, the term peripheral is used as it's used in neurofeedback almost to dismiss the technique. Oh, that's a peripheral technique. Well, it's not peripheral to the person; it's core to the individual, and your heart rate, and your blood pressure, and your electrodermal activity, and
Yeah.
all of these things are part of the person. They're not peripheral to the individual. So I
Jay, I'm
think
just going to jump
our
on, when
language
you're
is a little
talking about the
funky.
vagus nerve, we can put the whole bloody body into this. We're talking about messaging and messaging direction. Okay. One of the things I talk about, somatic pain versus, quote unquote, mechanical pain. Where's the pain coming from? If you bang your finger, it's coming from your finger to your brain back to your finger. Okay. But there are certain forms of pain where the messaging is exactly the opposite. It doesn't result from a primary injury, et cetera. And I think we're absolute fools if we think that everything only goes in one direction.
Yeah.
Now, all that said, we can get a lot of change and a lot of power working through the brain and having the messages go from brain to peripheral. But we are a system. We can't forget that.
And pain is something that we work well with.
Yes. Yes.
There's something called a thalamocortical dysrhythmia. Big, fancy, long term, but
Essential.
it's a primary failure mode in the brain, and it's associated with tinnitus if it's in the auditory cortex. It's pain if it's in the somatosensory cortex. It's a movement disorder if it's in the motor or premotor area. If it's at the anterior cingulate, you end up having a reward deficiency problem, and which includes some kinds of depression, anhedonia, amotivation, lack of initiation, cingulate problems. So, we need to um, kind of complexify how we think of where pain is,
Mhm.
and it's not always peripheral.
Yeah.
Years ago, I cut those four fingers off, and I had them stuck back on, but when they were cut off, I didn't feel the pain in my hand at all. I felt the pain in my shoulder. Severe pain can be gated. Your
Yeah.
body can turn off the sensation.
Yeah.
So, you know, it, you can end up turning off pain from the outside in or the top down. Uh,
Yeah.
and I worked with a neurosurgeon who worked specifically on pain, and he heard about the thalamocortical dysrhythmia thing, and he wanted to basically see if the patients who were complaining of chronic pain could be predicted. Now, he had a 50% success rate for his brain surgery to turn off pain. And that sounds terrible, doesn't it? I mean, half a chance. But if you get somebody with severe
No
pain
chance.
and you give them half a chance, they will line up for half a chance. But we basically just told him which cases that were complaining of chronic pain had the dysrhythmia and which ones didn't. If they didn't have that, we weren't saying they didn't have pain. We were just saying they didn't have the dysrhythmia, which is the kind of pain that surgery can work with. His success rate went to 80%.
Yeah.
Now, obviously, the patients that were told, "Well, we can't do the surgery for you," weren't very happy with the answer.
Mhm.
But the success rate went up from 50% to 80%. The people that were most happy were the risk management people at the hospital.
Mhm.
If you have a surgery and you didn't get success, the likelihood of you actually being upset with the hospital or the doctor and
Yeah.
litigating is higher. Now,
Yeah.
not everybody does, but it's enough of a percentage to end up wanting to end up with less of it.
Yeah,
So,
I mean, we can play with numbers and statistics, but I like that, in terms of, knowing what you're doing and why you're doing it and having all the information. We talk about percentage successes, but you're talking about individual successes, which is where the beauty of all of this lies.
now
Jane, Dr. Marie,
in
last question here. If a child hasn't spoken by age 7, is it too late for them to develop speech and communicate?
Nope.
not necessarily.
Yeah. Well,
Depends.
yeah, both Jay and I can respond. Jay, do you want
Not going to be easy,
No.
but it's entirely possible. I would point to an unpublished study by Dr. Kopatov in St. Petersburg, Russia. He was the head of neuroscience for the whole Soviet Union, and when it broke down with Glasnost, he ended up having to actually get a job and do treatments, not have a position overseeing neuroscience. So they started to actually do treatments. One of the treatments they did was with children with no speech. Now that sounds like a mute autistic to me. So they stimulated DC stim, activating the Broca's area, and they would bring the kid in on a daily basis, and they would give it a couple of weeks worth of trial. And one of the little kids, I don't know what the name was, but little Oleg came in and they stimulated, and they left for the done with the session, and they went out to the car to go home, and little Oleg started to speak. The parents came back in all excited. It worked. Little Oleg is speaking. He's full word sentences. And Yuri basically said, "Well, congratulations, your son can now speak. You don't need to keep coming back in. We turned things on. That's all it took. Yeah, so you now don't have to come in for the treatments." A couple weeks later, they came back in and asked if they could turn it down. You turn it on, and now he's talking, but
He's
without
acting like
enough.
a 2-year-old.
Yeah. So, but it can be done, and neuroscience is probably the thing that's going to do it. So, have the brain looked at carefully by somebody who looks with EEG and potentially MEG or functional MRI or something. But look at the brain function and see whether Wernicke's area, which is comprehension, is working. Because if you don't comprehend speech, you sure as hell are not going to be speaking it. So the whole system has to work. If there's a receptive language problem, it'll stop expression from happening. But it might be simply an expressive problem, and they fully understand what they're hearing. When little Oleg spoke, he spoke in full sentences. This wasn't acquiring language slowly like we do. This was having it already. He understood it already. He just couldn't speak it. So that was just speech motor.
Now we have to, I want to tag in on the motor there. We also can't forget about the component of some of the failing musculature responsible for the production of language as well. Yeah, but there seems to be, I'm very, very optimistic with most individuals that I work with under the age of 9. Between 9 and 10, much more fragile, and then after 10, the success just drops phenomenally, unfortunately. So that's your layering there, Jay. Yeah.
That's about the same age at which, if you move to another country, you keep your accent.
Yeah.
If you're really young and you move, you lose your British accent or German accent or Minnesota accent. Whatever it might be.
Chicago.
Chicago. So I'm from Fargo, don't you know?
Don't you know?
Yeah, but we can overwrite that until around 13, 14. But I mean, this is fascinating stuff, absolutely fascinating stuff. But I want to ensure that we don't give false hope to anybody who's a little bit older. But it's not all over. There's a lot that can be done.
Well, everybody that's listening and watching, and Tabaloo, thank you. If I got your name right, geez, I don't know. we picked him up from our live chat Wednesdays at 6 Central Time, 4 o'clock Pacific, 7 o'clock Eastern. It's a live chat on YouTube where we honor all questions. We don't always give an answer because it depends. Always check with your primary care physician or mental care taker. But I think we mix entertainment and information in a fairly common way, and I think we're doing okay. Jay Gunkel,
more responsible than average. How's that?
That's right. That's right. Dr. Marie Swingle, Jay Gunkelman, Tabaloo, thank you for another great episode of the NeuroNoodle Network podcast.
And Sky is right here on duty. So.
Busy Sky. Yeah.
He's making
before we sign off, I'm going to be en route next Wednesday, Thursday. So you're going to be flying solo.
Show up when you can. Show up when you can, just like everybody else.
Okay. All right.
All right, everybody. See you Wednesday.
Always good to see you.
Always good to be seen. Have a great weekend, all.
Bye.
Bye-bye. The NeuroNoodle podcast is supported by listeners and businesses just like you.